This is Krista. Welcome back to MadeToBeWhole. Stay tuned for an update on testing and interventions for PANS and PANDAS, aka autoimmune encephalitis.
MadeToBeWhole is intended for informational purposes only. It's not intended to replace the advice or care of a licensed healthcare professional. Participating in this podcast does not constitute a provider-patient relationship with Krista Michener, AHP Integrative Health, or any of the guests featured on MadeToBeWhole. Krista Michener, AHP Integrative Health, and any featured guests aren't responsible for any losses, damages, or liabilities that may arise from use of information obtained in this podcast or associated materials. Please consult a healthcare professional for any health-related concerns that you are experiencing.
This is Krista. Welcome back. We've mentioned throughout this podcast and had a few highlighted episodes the impact of autoimmune encephalitis, known also as PANS-PANDAS or basal ganglia encephalitis, but they're all under the same umbrella, the same thing, different ways to describe it. So the PANS-PANDAS label, I think sometimes we hold on to the things that are easier to pronounce, but those are abbreviations that are describing a phenomenon. So a pediatric acute-onset neuropsychiatric syndrome or a pediatric acute-onset neuropsychiatric disorder associated with strep for PANDAS. So it's just giving us a description of the condition, basically saying, okay, this is something that happens suddenly. It causes neurological, including psychiatric symptoms. It's associated with an infection, sometimes strep, sometimes other infections. It can also be toxins or other things that can trigger it. But I'm just going to, for the sake of simplicity and what I frequently do, use the phrase infection during this podcast when I'm talking about instigating events. So it can be abrupt onset, it can come and go waves. It is certainly life-altering for the individuals who have it and for their families. One of the reasons I shy away from the nomenclature of PANS-PANDAS versus autoimmune encephalitis is because I feel that there's a high risk for missing a lot of positive cases because of the P in PANS and PANDAS. So both of the P's in those names are pediatric, where in reality, I'm finding a lot of individuals who are not children or not even near the age of a child who are testing positive for autoimmune encephalitis. They're getting mixed. So let's talk more about the actual disease, autoimmune encephalitis, and why it's missed, how we can find it sooner, and when testing is a good idea for you. So autoimmune encephalitis. So encephalitis, breaking that term down, the encephal prefix, that's talking about the brain. Itis is inflammation, okay? So inflammation of the brain. Autoimmune, the way I basically describe this to people in terms of this particular disorder is you have an infection, and your immune system gets hijacked or confused or overworked or whatever. And instead of attacking the infection, your immune system attacks your brain. So it makes these autoantibodies, antibodies against the self. Your immune system is working actively against you, and it wreaks a lot of havoc. One of the best ways to diagnose this is using the Autoimmune Brain Panel. The Autoimmune Brain Panel is from the company Moleculara. It's an excellent science-based test. There's a great deal of research, past and present. There's an ongoing investment in research and education. It's a really, really good test. I was looking at their website today. They said the average reimbursement for insurance for this test is about a third of the cost of the test. It's currently, as of February 2026, it's a $995 test. You pay, I believe, $450 up front. They'll bill the rest to insurance. And then if you get any back, they'll reimburse you. They'll bill you for the balance. So on average, people are getting about a third of that back. That to me seems like kind of a drop in the bucket when we look at the value this can provide for someone who's been sick for a long time. And I would also interject there, you don't have to wait until you've been sick for a long, long time. If you think you fit the bill, finding the correct diagnosis or constellation of diagnoses sooner rather than later is going to save you time, money, and suffering. So autoimmune encephalitis, Autoimmune Brain Panel is a great test. There are some other things that can be used. For example, there is a commercially available test, the GAD65 antibody test. You're welcome to try it or see if your provider will try it. You can get it through your Quest or LabCorp. The problem is I've only had one person come back even faintly positive, and this is amongst people who have already had a very, very positive autoimmune brain panel and lots of symptoms that are consistent with it. So you're welcome to do it, but it's not necessary, particularly if you don't have insurance. I would jump straight to the test that's going to give you the most value. And one of the things that's really, really helpful is Moleculara on their website gives some ideas about what symptoms might be driving an illness that's not responding to treatment and when to consider this test. So when do you say, yes, I want to know, I'm going to do the autoimmune brain panel? Well, I would say there are a couple of different times. Everybody's got a different kind of trigger point at which they say, yes, I'm going to do that. If you or a family member is struggling with persistent neurological or psychiatric symptoms that have not responded to standard treatment, that's kind of a good summary of when to do it. And I would rather it be done before they have failed to respond to standard treatment and been failing for 10 or 15 or 20 or more years. Let's catch this earlier in the game. So neuropsychiatric symptoms, what are those and what is standard treatment? When we're talking about the mental health piece of this, because PANDAS or autoimmune encephalitis can have rather dramatic mental health symptoms, particularly anxiety, including an OCD type anxiety, paranoia for some patients, significant separation anxiety, being very, very clingy, needing constant reassurance. There is such a phenomenon as reassurance OCD. I recommend looking that up. It's pretty much what it sounds like, but just knowing OCD isn't just, I have to shut the door so many times or wash my hands so many times, or I have this ritual or that ritual. For some individuals, the ritual is seeking constant affirmation. So they are always needing reassured, yes, you're a good person. You're not a bad person. You haven't done anything wrong. Everything's going to be okay. You're doing the right treatment. You will find as a loved one of someone who's dealing with this, having the same conversations again and again and again. And just so you realize you are that person's security blanket. And I think that's okay. It's okay to set boundaries too. Obviously, just because somebody's anxious doesn't give them the right to barge into your work meetings, wake you up in the middle of the night every night, yada, yada, yada. Figure out appropriate boundaries for your situation, but recognize they're looking to someone they love and to trust to help them feel safe because they don't feel safe inside their minds. And these individuals, many of them may know cognitively and rationally the right answers, but that's not how they feel. And it's so intense. I will tell you, as someone who's dealt with this as a patient and as a family member, it was very reassuring to have a name for what was going on. So a little bit about me and I guess my personality and how these infections and the autoimmune encephalitis have interacted with that. I've always been a words of affirmation type girl. So you may be familiar with the 5 love languages, famous book written about. Everybody has their own primary love language. That's what makes them feel love. That's how they like to receive love. I typically joke that I am multilingual because I like all of the love languages except gifts. I don't really care about those, but I like words of affirmation and I like physical touch and I like quality time and I like acts of service. But most of all, I like words of affirmation. Do I know my husband loves me? Yes. Do I love him to tell me that frequently? Yes. Even though he may have done it very recently and nothing's changed. Yes, that's what makes me feel loved. But there are times that I am like constantly seeking reassurance. Am I okay? Do you still love me? Are we going to be together forever? I know all of those things, but when my brain is very inflamed, that's my security seeking mechanism. And part of how I know this is inflammation and autoimmunity related, because when I've found things that have worked for a while and had a relief in symptoms, I'll just lay there and think, this is something I would have bugged Eric about before, or he'll be having a bad day and I don't take it personally. Oh, well, of course he loves me. I mean, that's just logical. But when the brain's inflamed, logic is so hard to come by. So reassurance, OCD, it's more than just a personality thing. It's somebody using that constant reassurance seeking as an OCD type ritual because they are looking to feel safe. Because really, anxiety and OCD, it's a feeling of lack of control and trying to manipulate enough things to restore some sense of inner control. So what is standard treatment for someone who typically has OCD or anxiety? Well, obviously, that can include medication, that can include therapy. We've talked about a lot of alternative things that I also do for OCD and anxiety. But if you have done those things with very marginal improvements or no improvements or improvements that seem to last for a little bit and then stop, that would be time to consider the Autoimmune Brain Panel, because there are good interventions out there. But they're not going to be sufficient if your brain has not only attacked you, it's continuing to on a daily basis. It is under attack, and all of the cognitive behavioral therapy in the world is not going to change what's happening here. It can help you change some of your interpretation of it, certainly help with coping, but there's just a level of intensity when people have this, and a lot of them are patients who fall into my camp of, I call it working too hard to feel this bad. They're doing all the things they're supposed to, but nothing is getting significantly better, and they never feel safe or calm. Obviously, medication for mental health stuff, there are some people that really helps. But if you've taken every medication there is, I don't think you should have to go that far. But if you've taken multiple medications and they don't make things better or they make things worse, or I see this pattern too, they work for a little while and then they stop. You try another one, it works for a little while and then it stops. That's really, really important, because I see a pattern with lots of different interventions in this space where people will find something that reduces inflammation. It's effective for a while, and then the body just outsmarts you. It figures it out and finds a way. And so you're looking for the next thing and the next thing because you're always chasing relief. Also, if you have an atypical response or not an appropriate response to treatments for hormone deficiencies, if your hormones are a mess and you fix them and nothing's better, something else going on. If you have infections like Lyme, Bartonella, Babesia, a history of strep, viral infections, there are a lot of different infections that can trigger this presentation. But if you have a history of either symptoms always getting worse after you have an infection, not just a chronic infection, but say, every time I get a cold or if I get exposed to the flu, my anxiety gets worse, my pain gets worse, everything else flares. That's a clue. If you've had good treatment for vector-borne infections without a significant response, that's a clue. So all of these things are indications that maybe it's time to consider the Autoimmune Brain Panel, because if you have these autoantibodies working against your body, your brain, your nervous system, you are never going to get significant or sufficient relief until it's addressed. You just have to take care of it. So there are 5 different antibodies that are included on it. And on the Moleculara website, they've got some really nice educational material that shows you with each of these autoantibodies what are the most common symptoms. So the anti-dopamine D1 receptor antibody. This one's elevated for me and a couple of my family members. So what are the most common symptoms? Anxiety, check. Sleep disturbances, check. Depression, check. Mood dysregulation, check. Also irritability, aggression, rage behavior. That kind of manifests itself a little differently from person to person. But especially someone who has outbursts. If there's someone who they do things sometimes that are just out of character, and it's not because they're using drugs or something else. Like just think, is something's changed inside of them. If nothing's changed externally, why is it coming out this way? Psychosis has been known to be associated with this. And so just basically think dopamine, think what dopamine's supposed to do. It's supposed to make you feel happy and relaxed and all those things. If your dopamine antibodies aren't functional, your body can't get a regulation of dopamine, it's going to mess with your mood. The end. There are anti-dopamine D2 receptor antibodies. They have a lot more to do with neurological and movement type things. So tremors, if you think of a tremor, that is not just Parkinson's. That's not just other things. It's a neurological phenomenon. So it's figuring out what causes it. Hyperactivity. So even think in terms of treatment, if you've got an ADHD kid who no ADHD treatments or interventions seem to do anything for them, maybe they're moving because they feel driven like a motor because they've got something autoimmune going on. And I think it depends too on how much it's disrupting their quality of life. But if they're not able to have relationships and to function in a school or a work environment, that's a problem. You've got to look deeper. Along with that, just kind of generally any involuntary movements. So anytime something in your body moves on its own that you didn't tell it to move, that's a clue. And then chorea or choreiform movements. So chorea is a broad term. There are a lot of different types of chorea. For example, Huntington's is a very specific type of chorea, but there are choreiform movements. So basically those are any like involuntary, irregular, and unpredictable muscle movements that have a neurological root. So I have a lot of patients who will talk about what we call fasciculations, where you can look at your leg or your arm and your face and you see something moving. Some people have tongue movements, back and forth. They've got the tongue stuff going on. They can't move their hands the way they used to, all sorts of different things like that. So any involuntary movements. I have people who spasm and jerk a lot. And so I would definitely kind of put that in that category. If you hear loud noises or you have any like shock to your nervous system and your whole body reacts, that's an issue. Children particularly, they can have headaches, slurred speech, even seizures. Again, think if there's failure to respond to typical treatment and you can't find a good response. Now, these aren't rhythmic movements, but they're irregular. It's just unpredictable movement, and it can be in one part of the body, or sometimes it moves from place to place within the body. So all of those fall under the category of things that could be triggered by these anti-dopamine D2 receptor antibodies. Look at other causes, but if there's not one and it's persistent and you're not responding to treatment, that is definitely an issue. So then we go to the next type of antibody, anti-lysoganglioside GM1 antibodies. So ticks, not the type of ticks that bite and start all this, but TICS. So if you think of Tourette's, but other ticks, sometimes we will make an automatic assumption. For example, most people with Tourette's have motor tics. Therefore, all people with motor tics must have Tourette's. Well, even Tourette's is just a syndrome, I'll point out. We haven't, to my knowledge, figured out root cause of that, but you can have multiple causes for a very similar presentation. So tics, especially that develop suddenly and haven't been there before, or develop later in life without any sort of head trauma, other inciting events, it's really not normal. Headaches are associated with this. Neuropathy, joint pain, also connective tissue disorders. We talked about in some of our other episodes how there are a lot of connective tissue disorders that are common with Lyme and co-infections, particularly Bartonella. But is it possible in some of these individuals, it's not just the direct effect of the infection, but if this antibody response is triggered, that there can be accelerated connective tissue degradation or lack of formation. Also, even joint pain that can go with this. We see it a little more in the head, but joint pain can certainly happen. There's a broad range of things. Next, we're getting close to the end on our exciting antibodies, but your anti-tubulin antibodies, obsessions or compulsions, cognitive interference, which brain fog type stuff, poor concentration, and memory problems. Obviously, somebody could just get told, hey, you're getting old. Do the old people just get left out because you're old? It's okay that bad things happen to you? No, it's absolutely not. I've had people, I think the oldest person that I've ever tested for this is in their 50s, but they were positive. I've had plenty of people in their 30s and 40s test for this. Some of them had childhood onset symptoms. Some of them did not. So we need to look at this like we do other autoimmune disorders, in that they can occur anytime in life. It's true that from what we know, this probably happens more commonly in childhood. But again, I don't know how often we're checking for outside of childhood, but that doesn't mean it can't happen. Compare that to like type 1 diabetes. It used to be called juvenile onset diabetes. That's your insulin dependent diabetes. It used to be just a childhood disorder. And then they realized, oh, you actually can get type 2 as an adult. So think of it more like that. But definitely anti-tubulin antibodies can affect cognition. Just think anti-tubulin, anti-thinking is how I remember that one. Finally, one of the more famous ones, the CAM kinase 2 cell simulation assay. So often involuntary movements, especially this like overactive fight or flight sort of scenario where people get very, very dysregulated very easily, sensory sensitivities. So it is true that multiple chemical sensitivities or toxin-induced loss of tolerance, those things can trigger someone to be ultra sensitive to noise, to smells, to light. But it's also true that this autoimmune response can trigger that same thing. So if you have like cleaned your house, got rid of all the odors, remediated for everything under the sun, and then you still are oversensitive to things, this is something to consider. Enuresis, which is bedwetting, mood instability, sleep disturbances, fatigue. Going back to the sleep disturbances with that, what I would suggest is, again, looking at the pattern. Do I start something for sleep and it works for a while and then it stops? And then I have to try something else and something else. I see that very commonly in my patients who have autoimmune encephalitis, that they will find an intervention, but it's not going to last forever. I suggest if you're one of those people that you just keep kind of like your arsenal on board and you just rotate. If Benadryl sometimes works for you, take it till it doesn't and then switch to whatever else you have in your arsenal. That's a perfectly reasonable approach. The last one that I think is interesting is mydriasis, which is basically when your pupils dilate, but they dilate longer than they should and they don't respond to light. This is where I think sometimes people get very scared because they know that that can happen because of head trauma, and they're convinced that they must have head trauma or a tumor. You don't, in the classic sense. I mean, your head's traumatized by this inflammation, but it doesn't mean you have a tumor. It doesn't mean you've had a stroke, anything like that. But it does mean there's something going on neurologically, and this autoimmune stimulation of ongoing inflammation can cause that too. So a broad range of neurological symptoms. If you get a positive test, I would not dismay, because it's the long game, right? Positive test means you can stop spinning your wheels, trying things that are helping marginally around the edges, and you can focus on root cause. The root cause for autoencephalitis is two things. You have to take care of the instigating event. So if it was infection, if it was Lyme disease, if it was strep, if it was a toxin like mold, if it was a virus, whatever it is, you have to treat the instigating event. That's not going to be enough, though. You also have to treat the immune system. Do not make the mistake of saying, well, if I just treat the immune system, everything else will take care of itself. I've not seen that happen. I'm sure there are times it has, but in clinical practice, I'm seeing the absolute need to do both. Treating the immune system, there are a couple of different ways to do that. Again, short game, long game. Things that have short-term benefits. You've got IV steroids, and even oral steroids, they can be really helpful for severe flares. And for those of you who are all hating on steroids, if you or your kid actually responds to a steroid and it can keep you safe, take it, because there's a really high suicide rate with autoimmune encephalitis because of the amount of internal distress it causes. So if you can modulate or suppress your immune system short term to give you some relief, I would absolutely do it. That's not the long game, because you don't want to just be doing steroid infusions for the rest of your life, but you've got to do something fast that works now to keep you safe. Other things you can start for kind of your transition: LDN, low-dose naltrexone. It is not effective immediately. It can take a couple of months even to have full effectiveness, but it does help autoimmune dysfunction and it helps inflammation. So it does two different things. You've got to work up slowly, have someone prescribe it to you. That's a good one. Those things can buy you time where you get to the modulating the immune system in a way that's going to last, and that's either IVIG, intravenous immunoglobulin, or plasmapheresis, also known as apheresis or therapeutic cell exchange. Those are both good interventions. Both are really expensive and both are really hard to get insurance to pay for. So in those situations, you don't throw up your hands and say, oh, well. You start looking for solutions. I can't tell you what the solution is because I think everybody's circumstances are different, but I think there are solutions out there. For some of you, you may have the inspiration or insight that maybe mom's been staying home, she gets a part-time job, or dad gets a job change or picks up a second shift. Like, you have to empower yourselves and your families to kind of write your own rescue and find your own solution. It doesn't mean it's going to be easier. You might not need help from others, but just don't roll over and be a victim to this. Look for solutions, look for helpers. There's not a quick solution for sure, but I promise that you're going to be much worse off if you just sit and remain a victim to what seems like a hopeless diagnosis. You have to look for help. You have to look for the helpers and keep advocating, because this is something that there was a legislature that said insurance has had to cover IVIG for autoimmune encephalitis, but in about half of the states at my last count, including my state of Ohio, the state legislature said, no, it's not medically necessary. So now insurance companies can say, nah, we're not going to pay for IVIG, and they are completely supported by a nonsensical move by the legislature that they were not really qualified to make. But that's it. That's something you can do. You may not have tens of thousands of dollars to pay for a treatment on your own, but can you write a letter to your legislator? Can you get involved? Can you support others? There are things you can do while you're waiting. Other things that you can do that for flares, I have, for those of you who are watching, a bottle of some of what we do in flares in this house, or a collection of bottles. So last night I had two of my kids who have this, who have not yet been able to get full treatment, in really bad flares, very despairing, very agitated. And what I do then is I just say, okay, hold out your hand. Here's what I'm going to give you. So I give them some Advil. I like the liquid gels for these situations because they work faster. I give Advil and diphenhydramine, which is just generic Benadryl. And one of those 25 milligrams, these are both adult-sized people. You need individual dosing help from your provider. And then I also said, take some cat's claw. Cat's claw is an herb that's anti-inflammatory. I found it to be effective pretty quickly. There are a lot of things you take that don't work as quickly, but I think with this one, it's this nano emulsion. I do it under my tongue and hold it there for a while, then swallow. I think it's because it's more bioavailable in the way it's delivered, you get kind of faster effects, but you have to have like a toolbox. Okay. So those are some of the things in our toolbox. I've mentioned before, and this is on our website, but GABA-A, it is a magnesium lotion, because magnesium for some people absorbs better through the skin, that has GABA in it. That's also calming. Pro-resolving mediators, SPMs, are good at reducing inflammation and actually crossing the blood-brain barrier. My husband has multiple genes that make it difficult for him to absorb magnesium, so we give higher doses in different forms. Magnesium 3 and 8 is much, much better at crossing the blood-brain barrier. This has also got magnesium acetyltaurinate, but you've got to get brands that are like targeting the brain. They don't all get their cytoquel. It's got black tea extract, cysteine, turmeric, resveratrol. We've found that to be very effective. I've mentioned multiple times Dr. Zhang's AIM, which is sardentodoxycollis. I don't want people to be out there scribbling down, oh, I have to write down this thing. I have to get this thing. What should I take? How much? My point of all that is to illustrate, we know we have a chronic phenomenon in my house, and I have to have all the tools in my toolbox to help take care of people when there's a flare. Yes, we need to treat the root cause. We need to modulate the immune system. We need to continue to work on eradicating infection, but we have to survive in the meantime. And that means reducing stress and reducing inflammation. And so you do trial and error. You figure out, okay, of all these anti-inflammatory things, what would be safe for me or my family member? Which ones work? And remember, when someone's in a flare, they typically don't have the problem-solving ability to think of what they need to do. So maybe having it in one place and then reminding them if you get a panicked call, well, hey, go to the drawer in the desk by your bed, get out your kit there. I want you to go take X number of Advil and some AIM. I want you to take magnesium and use the cat's call, whatever. Give directions. Also note that all of the things that I showed you here are different in how they work. So most of them, now again, you need to clarify with your provider and be safe, can be taken together. So I can say, well, gosh, if someone's in a really bad flare, maybe I'm rotating and giving them something every 1 to 2 hours. Maybe we just keep going and we give them something every 1 to 2 hours. If you have someone who refuses to swallow pills, that's obviously a problem, or they won't even swallow liquids, or they're in a flare, they're refusing everything. Definitely like the GABA lotion, but other things that can be made into a lotion. Oxytocin can be made into a lotion. That can be very, very calming. I think it's a little more effective if you can get someone to either do the one that dissolves under the tongue or the intranasal. But if you have somebody who is unwilling to put anything in their mouth in that condition, and it's a kid that's screaming and thrashing, would they let you rub some lotion on the back? LDN can be made into a lotion. Other things that can be made into a lotion, Advil or ibuprofen, can be made into a lotion or cream by a compounding pharmacy. So you are not helpless if you have someone who is thrashing around and when they're in flares are going to refuse to take anything. Try to find other things you can do and try to modify the environment. Some people might need quiet and people to leave. Some people might need calming music. Some people might need someone sitting next to them. You have to adjust what you can in the environment. Sometimes using like an essential oil diffuser and getting some oils that are calming. Again, something that can help them that they don't have to actively participate in to reap the benefits from. And remember that your children feel your anxiety, your spouse, your sibling, they feel your anxiety. So we see this a lot with parents, and parents have heavy, heavy loads. But first of all, I'm convinced that about 50% of our kids with PANDAS, they have a parent who does. I'm convinced by just case studies of observing individuals. So first of all, that needs to be addressed. But also remember, if you are stirred up and anxious because you're so worried about your child, they're going to feel your anxiety, and that's going to reinforce how they feel. And it's just going to feed on and on and on. So you cannot control what's going on around you. You cannot control this child. You cannot stop what's happening from happening, but you can control yourself. And if you need to, before you go in that room, put some GABA lotion on yourself. If you need to take some magnesium or what it is that makes you feel calmer, then do it. Prepare yourself physically, mentally, spiritually. Take a breath, pray. Remember, you cannot reason with someone who's in a flare. So don't try. Don't tell them they're being irrational. Yes, they're being irrational. It's called a flare. That's okay. It's your job to ensure safety and just be present. And sometimes that means evaluating the situation and then stepping outside to give them space because they need space, or because it's someone who is a risk to you or others, or is being so unreasonable that engaging is going to harm them more. It's a difficult thing, but I think finding support and finding counselors or other professionals who actually understands how this affects an individual and their family can be really, really important. You cannot take accountability for someone else's actions, but you can take accountability for your own. So if you're a caregiver, take accountability for your actions and then help. If you're a patient, you may not love the way everyone in your family is responding. Focus on what you can control. Nobody is served by going around trying to, even though it's well-meaning, manipulate the agency of another. Focus on what's in front of you. And remember, even when it's hard and painful and it seems like it's not worth going on, it is. And you should always have hope because you were made to be whole.
Have a podcast question or suggestion? Text or call us on the podcast info line at 330-439-0686. Thank you for spending time with me today. If you like what you hear, please subscribe to be notified when new episodes release. And remember, you were made to be whole.